This week we'll be looking at benign and malignant breast disease. So we'll start with fibrocystic breast changes that are linked with menstrual cycles, and then we'll get into cysts and fibroadenomas, followed by benign tumors, and then breast skin lesions, and then we'll finish up by having a brief overview of breast cancer. So fibrocystic changes. This is the most common benign breast condition. It can be referred to when you're doing an assessment as just feeling lumpy breasts, cystic breasts, painful breasts. Basically, these are symptoms that fluctuate with the menstrual cycle. So typically, women will feel more tender at the very least prior to their periods, and then they might also feel like there's kind of lumps and bumps that kind of ebb and flow with their cycle, is what I hear it described most commonly as. So if women are doing breast self-awareness by checking their breasts every month, then the most convenient time to do this would be after their period, and maybe in the shower would be even better because it's just kind of slippery and easy to feel. But after their period's going to be when we would expect the least amount of fibrocystic changes and the least amount of tenderness, so that would be a good time to do it. So this is not a risk factor for cancer, and most women actually do have a regular, tender, lumpy breast premenstrually. So this isn't a disease, but it is a normal process. That said, it can make examining breasts a challenge, and I think there's something to be said for as soon as a provider starts to feel that there's somewhat a lot of lumps and bumps, that it can be easy to just dismiss the rest of the breast exam. So this is my plug for continuing to pursue a really careful exam. And if you're finding that it is just really hard for you to be able to provide a sufficient exam as a clinical breast exam, you may even want to consider doing a baseline ultrasound, just so that you have something you can look back on if year after year it's just really hard to tell what's going on. So I'll put that plug in for women who have particularly fibrocystic breasts. So interventions, basically we want to relieve anxiety about it by teaching about normal breast changes, and then also teaching how lifestyle and diet can impact the degree of those fibrocystic changes. So things that can be helpful, especially for reducing tenderness, but even just the fibrocystic changes. Caffeine restriction, salt restriction, especially those 2 weeks leading up to periods, and then supplementing daily with vitamin E or evening primrose oil, and then wearing a supportive sports bra. And this would be like all the time, like they could sleep with one too. So all of that can be helpful. The sports bra more so for tenderness. So here's what it can look like. You can see that it's along the duct pathway there at the terminal end. So, basically cysts are fluid-filled sacs that fluctuate with hormones. So that's the easiest description I can think for it. And they take up room, and you can see that as it's pushing against the adjacent tissue, that can cause some pain or cause some tenderness. So that's what that's coming from, is that extra cystic growth. So breast cyst characteristics. Most common breast lump would be a cyst. So it's a fluid-filled lump. Feels soft to firm, mobile, perhaps tender, and it's going to feel fluctuant, right? Like you'll probably be able to tell that it's fluid-filled. You could have just a single one, or it can be multiple. They can vary in size. Usually it's bilaterally, and that's reassuring that it is fibrocystic change. If you can find it on both sides, the chances are that it's not something that's going to be concerning. Most common in women 35 to 50, and it's pretty rare after menopause because it's so hormonally linked, unless they are on hormone replacement therapy. So, so they can be painful or painless, and ultimately they can be confirmed by ultrasound. So ultrasound is going to detect if something is fluid-filled or not, whereas a mammogram wouldn't be able to make that distinction. So let's just take a look at these images here. So these are all ultrasound images. Again, they're best at distinguishing solid from fluid-filled masses. And it's also easier to interpret in women with denser breast tissue. So if a woman's less than 35, you're probably going to want to go to an ultrasound before a mammogram, because mammograms aren't very good at being able to distinguish denser breast tissue. So our younger gals have denser breast tissue, so that would be more meaningful for diagnostic imaging. So if we look here at this one on the right, we can see really distinct, nice, smooth borders, and it's clearly fluid filled. So that's that dark color is representing fluid there. So what we want to watch for, not that we're the ones that are interpreting these images, but basically irregular, obscure borders would be worth biopsying. So this one is probably fine, but would definitely be worth biopsying. And then this one looks concerning, based on the irregularity of what's filling the fluid, but then also looking at the borders. And then something else that they can also do is look for vascularity. So in that upper right picture, anytime you see that red dot, that's going to be an artery, and then the blue are veins. So if it's highly vascularized, that would also be concerning, because tumors want to make their own blood vessels and give themselves their own supply. Great. So looks like I put a little note in here for this left image. Okay, so this one's very typical. That's the classic cyst look. And then over here, this is actually fine too, though it would be considered an atypical cyst. And then on further investigation, they found that this one was infected, but it was benign. Okay. So breast cyst treatment. Basically, do we need to treat it or not? So usually we're not going to do anything unless it's painful or particularly unsightly, and that can be determined by the patient as well. They'll keep in mind, I mean, if you can aspirate it easily, then that's fine, but if for some reason it needed to be incision, then you're also weighing the pros and cons of possible scarring. So typically aspiration would be fine though for a cyst. So treatment is aspiration by fine needle under ultrasound, and it can be all sorts of colors. It's typically not clear, and then the fluid can be discarded, or if there is any concern, it can be set to cytology. There's about a 20% recurrence risk, so just because we aspirate it doesn't mean we're done necessarily, which is nice to let women know about before it pops up on its own. So here's a fibroadenoma. So take a good look at that. You can see it doesn't look fluid filled, it looks more fibrous. And now we'll talk about it. Okay, so, oh nope, we're looking at it again. Okay, so fibroadenoma on ultrasound, fibroadenoma on mammogram. So if this was done on mammogram, probably this was done first and then an ultrasound would be done, because wouldn't be able to tell if that's fluid filled or mass filled. So an ultrasound is a good follow-up there. You can see it's got well-defined borders, right? That's crisp borders there. And it looks like we're just describing it as an ovoid mass. Okay. And then ultimately, you're going to know what it is based on needle biopsy. So you can see this is the ultrasound transducer, and then the needle biopsy there. Okay, so solid benign fibrous tumors. It's the most common tumor in women under age 30. Painless, typically smooth, mobile, rubbery mass. It's not changing during the menstrual cycle, so that's distinguishing it from our cysts. It might be found on mammogram. You need a biopsy to officially diagnose it. It can be removed if it's large or painful. And again, we're thinking more so about potential scarring with excision on these, since probably we wouldn't be able to just aspirate it out. Usually they'll stay the same size or regress over time, so not generally something to be concerned about, but again, if it is painful or particularly big, then that could be something that can be considered. If it's smaller than 3 centimeters, they can do a vacuum assist to get it out, so that's something to consider as well. And it's not terribly uncommon for a new one to emerge in the same spot, so it can recur. Okay, other benign tumors, papillomas. This is the woman that comes in and tells you that she's got a bloody nipple discharge. And basically what it is it's a wart-like growth. So you see that papilloma and you think the human papillomavirus causes warts. Papilloma is in reference to the skin changes there. So a wart-like growth, no relation to HPV, just as an aside. So a wart-like growth that's underneath the nipple, so it's further inside. Sometimes you can feel it, but typically you're not going to be able to feel it, though of course you're doing a full exam. If you do have a woman come in with a bloody nipple discharge. So most common 35 to 50. Typically it's just affecting one breast, and it could affect 1 to 2 ducts. So probably you're first sending this person to get a mammogram, and then perhaps an ultrasound as follow-up to that. But ultimately, for definitive diagnosis, it's going to be a galactogram or a ductogram. And these are always surgically excised because while this is not cancer, it can be precancerous. So the surgeon's going to want to know the location, so that's where the galactogram piece comes in. But early breast cancer cells can sometimes be there, so DIS level. So here's a papilloma on a mammogram on the left, and it usually wouldn't show up on a mammogram, but in this one it does. And then over here we have the ductogram. So you can see that 1 to 2 ducts are affected in this one, basically just this one. Okay, but a mammogram is still worthwhile even if you're highly suspecting a papilloma, because it might detect another concerning kind of a mass. So say it was due to breast cancer and not due to a papilloma, we'd want that mammogram to show that we've ruled that out. Other benign tumors. Okay, so we have sclerosing adenosis. So that's basically, you know, the word like atherosclerosis means hardening, right? So basically it's a hardening within the lobules of the breast, and it's seen as calcification on mammogram. And it looks kind of spiky, so the way that it hardens and calcifies looks kind of spiky on mammogram, which mammograms are very good at being able to detect calcifications. So all these changes are benign and remain within lobules. There's no threat to the patient. And then lipomas, basically it's adipose tissue masses that can sometimes, I think of them as fatty tumors that can sometimes occur in the breast, and they are oil cysts or galactoseals, can be what ended up causing them. Again, no threat, but they can be removed if they're uncomfortable or if patients want a cosmetic shift there. So galactoseals or milk cysts, usually this is happening during lactation. So common ages are childbearing years there. Obstructed duct distended with milk, so you have basically like a blocked milk duct. Appears similar to a cyst on ultrasound, and it's well circumscribed. It's benign, and if there is a lipoma associated with it, aspiration can help. And it's probably just going to consist of adipose tissue. So no threat, it can be removed. As long as it's not infected, it would be fine. Okay, so moving from masses over to skin lesions. So first off, we have cellulitis of the chest wall, which basically is going to present as cellulitis would anywhere. So erythema, tenderness, edema, no signs of it necessarily spreading. Occurs in post-mastectomy patients, and it can also occur during radiation therapy, and even years after treatment. So the treatment would be antibiotics, and occasional chest wall debridement with grafts is sometimes needed. If you have somebody with this coming in, this is where you pull out your Sanford Guide pocketbook and you look up skin, and you can see what's going to be most effective for treating skin or cellulitis. Or you can get on Up to Date or another one and see if anything in particular is recommended for cellulitis. So just thinking about where are you going to go to find the best antibiotics for what you're trying to treat. Okay, in fungal infections, Candida albicans, thinking, oh, I was going to show a picture here. I'm going to pause it for a sec. Okay, picture here. So this is a pretty extreme case, but you can see this Candida is all up underneath her breast. So you can see by the erythema, and then you can see that there's just little bits of erythema that come off of it too. So we call those satellite lesions. That's classic yeast. So seeing those little red dots that are kind of beyond the base area of the red dots. So much more common for women with pendulous or large breasts. And so this is our warm, sweaty, yeast-growing bacteria area. So one thing women can do to prevent it would be to use something like Gold Bond under their breasts every day, but we can use nystatin if it is infected. So local and systemic antifungals would be the direction you would go there for treatment. Okay, so up here we've got eczema of the nipple, might come in. You can see what it might look like, but then also coming and reporting that it's particularly itchy. And then hydrocortisone would be your first go-to there for treatment. Sebaceous cysts are what I put down here. So basically it's multiple infected sebaceous glands. So dermal in origin, and then you can use antibiotics. So these ones look just a little bit older to me, and then these ones are a little bit fresher. But these ones are pretty deep cysts. I'm showing you guys the worst cases. Okay, and then Montgomery glands are small raised areas. Well, we already know what those are. So just to be aware that sometimes they can become clogged and infected as well. So those oil glands, the little bumps around the areola, which I've got multiple breasts on here, but no obvious Montgomery glands to point out. Kind of obscured with other things. Okay. Inflammatory process. So we'll put a few up here for inflammatory processes. So mastitis is going to be the first one, and obviously we know we're going to get this again once we hit postpartum next semester, or whenever you're taking intrapartum and postpartum. But for mastitis, so that's a breast infection. It can be related to lactation or not. Definitely we think of it as more associated with lactation, right? So inflammation from infection. So usually what happens is you've got milk stasis, and then that causes it to balloon out a little bit, and then bacteria enters, and then you get an infection in the duct. So and then a lot of that inflammation is actually just blood vessels coming to get to the infected area, so that engorgement that can kind of happen alongside of it isn't related specifically to the infective area itself as much as all the extra inflammation. All right, so usually it's peripheral areola of breast in one quadrant, so it tends to stay in its appropriate area. So symptoms: pain, redness, possible mass, flu-like symptoms, so feeling achy and has a temperature and just really overall is not feeling hot and is just kind of zonked in bed. That's how I think of these women. Usually it's Staph aureus. Treatment is rest. You tell women the basics like rest and increase your fluids, but whatever you can do to really hit that home. It's the moms that are up and doing too much too soon, and then also our moms that are not off to a great start as far as having a good latch so that babies can easily be extracting milk from all of our ducts. Either one of those things, I think of, those are my moms that always get mastitis. Not always, I don't want to say always, but classic mom to get mastitis, I suppose. So we're going to do rest. We can apply warmth and heat and massage and hot showers to that area. Basically, we want to prevent a mass. That's our goal. Prevent an abscess, or help break down the mass if it is there, and get milk continually moving. So, increasing fluids, continue nursing, especially from affected side. If there's pain, you can do like ibuprofen would be great as an anti-inflammatory. And then you can do probiotics, homeopathies like belladonna, garlic. So, and then varying our nursing positions, and really focusing on a good latch, just to help with milk drainage. So definitely wanting to nurse the affected side. Okay, so so this would be a good time for you to fully assess breastfeeding, and then certainly you can be the one providing that lactation support. But if this mom was just really having a lot of trouble based on your clinic schedule times and everything, considering a lactation consult and referral would certainly be appropriate here. If breastfeeding was part of the mix, and then antibiotics are required to prevent sepsis, and that cutoff is if we've hit 24 hours with the fever, then we need to be starting antibiotics. And if an abscess does occur, surgical intervention may be indicated, so incision and drainage, possible removal, antibiotics would all come with that as well, so you could refer out for that. Okay, continued inflammatory processes. So ductictasia, most common near menopause. Basically, this is when the ducts dilate and fill with cellular debris. So that's this picture over here. So it's getting wider and just kind of filling with gunk. So we have a thick nipple discharge. It can be anywhere from light gray to greenish or even black, and it can cause itching and irritation. So it doesn't feel well or great, and then it has the potential to become infected, but it's not a given that it would be infected. And if it does become infected, then that would require antibiotics. So it tends to be worse in cold weather. So fat necrosis then is a lump that most common is resulting from injury. So that could be surgery or car accident would be examples of injury. So basically it's like a walled up hard mass. And really any nipple change is worthy of a full workup. But it might appear suspicious on mammogram or ultrasound. Ultimately, a biopsy is going to be required to rule out cancer in this case. So, because it can cause that skin retraction and that dimpling. So, so realizing that even people who come in with something that seems like classic cancer, there's plenty of other things it could be that aren't really a problem, right? So, benign lump might feel hard. Skin retractions, dimpling, those are all things that go ding, 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 I need to work this up for cancer. That doesn't mean we have cancer. Okay, so Mondor's disease, I'm going to show you a picture and then come right back to the slide. So basically it's this super inflamed vein here. There's a few different places it could be on the breast. So let's have that picture in our mind and then read. So Mondor's disease is a phlebitis on one of the three superficial veins of the anterior chest, breast, or abdomen. So people present, it's really painful in the lateral half of the involved breast or chest wall, possibly into the abdomen. So it's painful, tender, and it looks like a firm cord. We don't really know what causes it. Maybe it's blood stasis from pressure on the thoracic veins. It might be direct trauma to the vein, surgical procedures, infectious process. We're not really sure. But if you see this, treatment is anti-inflammatory meds, heat application, and a well-fitting bra just to prevent movement because that can be painful as well. So we're not using antibiotics and we're not using anticoagulants. So again, Mondor's disease. And then intermediate tumors, we're about to get into breast cancer, but atypical hyperplasia, so changes in cellular structure of cells. So we're starting to notice some changes. That's not malignant, but it is abnormal and it could be considered precancerous changes. So if we do note that when we're sending people out for their workups, if this is what we're getting back, increased risk for developing cancer is about 5%. And then if they do have a strong family history, then that'll go up. So you could have atypical lobular hyperplasia if it's found in the lobules, or it could be atypical ductal hyperplasia if it's found in the ducts. So thinking back to breast anatomy. Okay, so atypical ductal hyperplasia could eventually turn into DCIS, which could ultimately end up as invasive ductal cancer, just to see that progression. So DCIS is basically saying this is precancerous, but it will develop if we don't do something. So if we do have atypical ductal hyperplasia, basically we're always going to excise, but it's not like we'll need radiation, and then it's worth watching every 6 months with imaging for 2 years. So just knowing that progression. Okay, breast cancer. Let's start by having an overview of what the statistics currently are for breast cancer. So 1 in 8 women will be diagnosed with breast cancer in their lifetime. These first couple ones are ones I like to tell all women when I'm doing my clinical breast exam. So even if a woman has no family history, she still has a 1 in 8 chance, which is pretty high. So I think of all the moms I see as being at a relatively high risk for developing breast cancer at some point in their lives. For men, that risk is about 1 in 1,000. 85% of breast cancers occur in women with no family history. So again, that's part of my spiel, since most of my women don't end up having family history anyway. And that risk doubles if women have first-degree relatives with breast cancer. So sisters, daughters, mothers. It is the second most diagnosed cancer, skin cancer being first. And then 5 to 10% of breast cancers end up being linked to gene mutations, with BRCA1 and 2 being the most common. Incidence and deaths began decreasing in 2000, so a few different thoughts for why this is happening. Possibly it's due to decreased use of hormone replacement therapy once we realized what a strong link the two had together. Early detection, and then more effective treatments have all been proposed for reasons why our rates have gone down, at least for deaths. Okay, so race. White women have a slightly higher incidence of breast cancer, though African American women are more likely to die from breast cancer. And they actually do have a slightly higher incidence if you're younger. So African American women are a little bit more likely in their younger years to have breast cancer. And then for our other groups, Asians, Native Americans, Hispanic women, they all have a lower risk of developing as well as dying from breast cancer. So in 2014 in the U.S., we had about 233,000 new cases of invasive breast cancer, 62,500 new cases of non-invasive breast cancer, and then about 40,000 deaths related to breast cancer. So that's where it currently stands. So let's talk about risk factors. So I starred our top 2 risk factors being gender, or being female, and then age. So basically, direct correlation, the older you get, the more likely you are to develop breast cancer. So other risk factors include hormone therapy. This is really based on solid evidence. So estrogen-only therapy evidence is a little bit mixed, but most hormone replacement therapy is going to have both anyway, estrogen as well as progesterone to counteract our estrogen. And yeah, so breast cancers can be particularly receptive to particular hormones such as estrogen or progesterone. So that's where that piece is coming in. And then iodizing radiation. So breast exposure to radiation, or even just chest exposure, is associated with an increased risk starting 10 years after exposure and persisting lifelong. So it's dose dependent and age dependent, and the highest risk is in puberty. So obesity is associated with an increased risk in postmenopausal women who haven't used hormone replacement therapy. And basically after menopause, adipose tissue starts producing more and more estrogen. So that's where the correlation is thought to, why the correlation is thought to exist there. And then alcohol is also associated with an increased risk, and that's dose dependent, thought to compromise the immune system. And then major inheritance susceptibility, like inherited gene mutations, would be another risk factor. Alright, so factors associated with decreasing risk of breast cancer. So exercise, boosting our immune system, really solid evidence there, even up to a 30% reduction in risk. So that is correlated with strenuous exercise for more than 4 hours a week in order to get that benefit. So even just translating that to an hour of brisk walking 5 times a week would put you in the right ball. Early pregnancy is also associated with a decreased risk. And then for breastfeeding, women can add up all their babies and all the months that they spent breastfeeding. And for every 12 months of breastfeeding, they get about a 4.5 risk reduction in breast cancer risk. So you could add it up. We know we've studied it up to 2 years. So up to 2 years, that would be a 9% risk reduction, etc. So we know American Cancer Society as well as the United States Preventative Task Force have both put out guidelines. I'm just highlighting the American Cancer Society's guidelines for this PowerPoint, but realizing that the United States Preventative Task Force guidelines would say start mammograms at age 50 and then continue doing them every 1 to 2 years. So we've got that in the back of our minds, and then we're contrasting that with the American Cancer Society's guidelines, which I've outlined for us here. So breast self-exam is optional beginning in women's 20s. So ultimately we want breast self-awareness is what we're going for. And I recognize this is review from health assessment. So then we have clinical breast exams periodically. So starting in your 20s and 30s, that should be about every 3 years. And then once you hit your 40s, that should be yearly. And then yearly mammograms starting at age 40 would be the American Cancer Society's recommendation. And then there's no stopping age unless someone's suffering from serious chronic health problems, basically looking like we're not going to be alive all that much longer anyway, or there's so many other things going on. This just isn't worth chasing, basically. So no stop time for mammograms. And then if women are particularly at a high risk, then you could also consider using an MRI for screening purposes. Again, not diagnostic, but screening. Or not chasing down problems is what I'm trying to say, but doing this on the front end when you're not suspecting something. So in order for this to be recommended, we need a 20 to 25% increased lifetime risk of breast cancer. And even then, I feel like saying recommended is a little bit too strong. It's worth weighing pros and cons and deciding what that's going to look like. And that would not be in place of a mammogram. That would be in addition to a mammogram every year. So women with a particularly strong family history of breast cancer or ovarian cancer, known BRCA1 or BRCA2 gene mutations, or you could also say like if her mom had tested positive and she hadn't gone through the testing yet herself, that would be something worth considering. History of radiation therapy to their chest between ages 10 and 30, or personal or first-degree family history of any of the syndromes that are associated with an increased risk for breast cancer. So those would all be things to consider. So while it's a somewhat weak recommendation to consider doing an MRI, they do make it clear that they would actually be against using MRI for screening if it was a less than 15% increased risk. So that isn't something you're going to jump to quickly. And then just in general with mammograms, we know that they can lead to unnecessary follow-up, and you can also miss some cancers. So we know mammograms aren't perfect, but American Cancer Society at this point is still saying that they are considered valuable for early detection, even as early as the 40s. So that's their stance. So let's delve into mammograms just a little bit more. So it's used for both screening as well as diagnostic purposes. So you're doing it, you're ordering it routinely for your women over 40, and then you're also using it if people are presenting with lumps or whatnot. So it identifies masses and calcifications. So remember, we're kind of comparing it to ultrasounds. So masses, yes, and then calcifications is unique for mammograms. It can't distinguish between cystic and solid masses. So oftentimes an ultrasound would be ordered after a mammogram if something needed further clarification. And then the sensitivity is limited by dense breast tissue and implants. And again, ultrasound doesn't have an issue with those things. And it can be used for localization for biopsy. So you could use that to help guide biopsies. And then requires radiation exposure. So to do a mammogram is to get more radiation. which we do know is a risk factor for breast cancer. So all these things are taken into account. So when mammograms are done, it's taken at 2 angles, so horizontally and then obliquely. So you can see this would be horizontal, and then this would be oblique. And the oblique way, the medial lateral oblique angle, that has the greatest amount of tissue in a single image. And then you can see that it also includes the pectoralis muscle here, and the axillary tail is there as well, as opposed to the craniocaudal angle, or this one here. That one would include medial breast tissue, but overall not quite as much breast tissue as the first one. So you do both of them, and then this is like right versus left. And then ideally you want to be going to the same place every year to get your mammogram, because they can compare one year's images to the next, and every machine is going to be just a little bit different. So to keep it consistent to one place, and then you don't have to worry about getting images faxed over to a new location, etc. Just makes for more consistent tracking. Okay, so how might we see a rating then? We send somebody for a mammogram, and this is how the results would come back. And we call this the BRAD system. So, so category 0 basically just means, oh, we saw something that we can't see very well, we need additional imaging. 1 and 2 mean basically fine. 1, didn't find anything. 2, we found something, but it doesn't matter. Both of those two, category 1 and 2, mean they're good for another year. Category 3 means this is probably benign, but let's do repeat imaging. So somewhere between 6 and 12 months, which 12 months is our schedule anyway, but just to see how that would play out. And then category 4 means that something is kind of suspicious here, and we're probably going to consider a biopsy. And then 5 is highly suspicious, and then 6 is a biopsy-proven cancer. So that's the BRAD scoring. So mammograms do detect 75% of cancers before they are palpable, so that's definitely valuable. And 90% of the time, normal findings. 10% of the time, we need additional workup. And with that additional workup, 85% end up being classified as BRADs 1 or 2, which means we're good for another year, no problem. And then of those, 10% are going to require biopsy. And of the ones that do require biopsy, 80% no problem, 10% malignant. So just to kind of see that, how that would play out. Versus ultrasound. So ultrasound's used diagnostically, but not for screening, generally speaking. So, so we're not doing this as our routine screening method. We're doing this if we find a problem on exam, or if we find a problem on our mammogram. That's when we would consider doing an ultrasound. So identifies masses, but not calcifications, but does do a good job distinguishing cystic versus solid. And then sensitivity is not limited by dense breast tissue or implants. So something to think about if you do have a woman who's at particularly high risk of breast cancer, say her mom got breast cancer at age 38, and so you were going to start doing higher screening for her starting 10 years sooner, so age 28. It would probably be to her benefit to do something like an ultrasound versus a mammogram, because her breast tissue is going to be so dense, a mammogram is only going to show us so much. So you might even consider doing both, but just something to be mindful of for younger gals. Ultrasound is going to be more meaningful. No radiation exposure, another benefit, especially if you're going to start early. And then it can be localized, or it can be used for localization, biopsy, or aspiration, which I personally see that as being quite a bit easier than using a mammogram for that purpose. Okay, so breast cancer treatments then. 3 essential considerations: local, regional, and systemic management. So local, we want to get rid of the cancer and prevent local recurrence. Regional is thinking about staging and prognosis and preventing regional occurrence, so we're thinking more about like lymph nodes there. And then systemic management is wanting to improve overall survival and then preventing distance recurrence, so it's not popping up in other places. So invasive breast cancer, if we were to think about what types of treatment modalities would fall into those 3 categories, Local management would involve like a lumpectomy or a mastectomy, radiation as well. And then regional management would be thinking about sentinel node biopsy. So, so say someone goes to do a biopsy, or even say somebody goes to do a lumpectomy, a surgeon does. They would take out the lump, and then they could inject a radioisotope dye prior to surgery, and they could see what lymph nodes were draining that particular lump. So rather than, say, taking out all 15 lymph nodes, they could take out the 3 lymph nodes that are definitely draining that lump. And then that way you would have less edema in the arms, less risk for nerve damage, etc. And then those, 1 to 3 nodes that were found to be draining that breast tissue, that could be sent to pathology. And then if they were definitely found to be cancerous, then you could certainly go back for more, but it's a little bit less invasive that way. So that's sentinel node biopsy. Sentinel is referring to the nodes that are draining that specific lump. And then axillary node dissection, basically on the same lines. So those would be regional management. And then systemic management would be chemo, and then any kind of systemic like PO medication. So hormonal therapies, immunotherapies. So those are coming up here. Okay. I lost in my slides here. Here we go. Okay, so surgical options, partial mastectomy, or you might think of this as like a lumpectomy. So taking out just the lump where we see the issue, and it looks small enough that we can just go for it. Total mastectomy is taking out all the breast tissue that would be affected, and then a modified radical mastectomy is the breast tissue along with axillary nodes. And then a radical mastectomy is basically not done anymore, but that would be the breast, the lymph nodes, as well as the chest wall. So you can see here's a partial mastectomy, also known as a lumpectomy. So we just cut, make an incision, take it out, and then suture it back up again. I say we, but I'm referring to the surgeon you've referred this gal to. As opposed to a total mastectomy, typically breast cancer is going to be found in the lobes, and all of the lobes are going to go to the nipple, so usually the nipple has to go if you're going to do a total mastectomy. So you can see here, the nipple was removed along with all the breast tissue, but like in the OR they would retract this area around and around and then cut inside to pull out all of the lobes without having to do a particularly large scar, ideally. So factors influencing surgical options in terms of how much they're going to try to take. So ability to receive radiation, previous radiation exposure, connective tissue disorder, inability to get to a radiation center conveniently, all that kind of thing. And there's to a certain extent, you max out on how much radiation your body can take. So the previous radiation exposure, that's where that comes in. If it's all confined to one area versus if there's a lot of different areas, that multicentricity component might mean we need to go for, say, a total mastectomy versus just a lumpectomy. The size of the tumor in relation to the breast size, cosmetics, and then patient's choice. So all of those things would factor in. Yeah, and as far as patient choice goes, I mean, you can survive just as long with a lumpectomy as a mastectomy, assuming that somebody's a good candidate for having a lumpectomy. Though it's interesting, I mean, I don't really have time to delve into it here, but just even cultural differences across countries, like in the US, we're a lot more likely to go for a total mastectomy versus in Europe. They do all that they can to save the breast and are a lot more likely to go to a lumpectomy. Thinking of France specifically, where I've read about that, but just interesting. So reconstruction surgery is optional, but typically if it's done behind the chest wall here, you can see this is behind the muscle, we can put a flattened implant with a port, and then that's often combined ultimately, well, so over time then we balloon this up so that the skin tissue has time to stretch there, right? And that's happening slowly. And then once we're ready to do the full reconstructive surgery, it's oftentimes combined with a tummy tuck. Or skin across the lateral side here can also be used, but then it would be, so it's her own skin would be moved to that location. So chemotherapy, the goal is to reduce recurrence and improve survival. So indications would be if you have an invasive cancer that's decently big, or an invasive cancer that's not necessarily big but a really high grade, or you have lymph node metastasis, or especially if you have HER2/neu and it's amplified. HER2/neu positive is what I'm trying to say there. If a woman's premenopausal, all of those things would mean we'd be more likely to go towards chemotherapy. And again, I'm saying we, but at this point we've basically referred, right? So, but we want to be familiar with this to provide anticipatory guidance, as well as when she does come in for her random primary care issues, and we're checking in to see how she's doing, everything she's saying is roughly making sense to us, right? So basically chemotherapy, you can do it prior to surgery to shrink a tumor, or you can give it after surgery is completed. So it can be done either way. And then oral chemotherapy agents, hormonal therapy is, it's nice if their hormone receptors are specific to, say, estrogen and progesterone, because it's easier to treat it by targeting it. And chemotherapy is becoming much more individualized to patients and to cancer type. There's a few different companies out there, like the MammaPrint, for example, where you can send tissue away and then learn the chance of recurrence with that tissue with or without certain types of chemos. So definitely becoming more and more individualized. So two basic types: selective estrogen receptor modulators that are blocking estrogen receptors on the cancer cells. So tamoxifen is an example of this, as is raloxifene. And then we have aromatase inhibitors, which are blocking aromatase enzymes in the adrenal glands, ovaries, fat, muscle, liver, other tissues. So basically it's stopping the body from making estrogen altogether. So a couple examples of that are there. And then again, all of these are used for cancers that are particularly estrogen or progesterone sensitive. So if they're feeding off of it, then that's what we're trying to block. So estrogen, progesterone. And then Herceptin I just put on here, that's a HER2/neu amplified cancer would be when you would use something like that. That's the main one I see there. Okay. So radiation therapy, that's going to be standard of care when breast conserving surgery is performed, or to axilla and select cases. So standard external beam radiation therapy would be the entire breast, and then typically what that looks like is 5 days a week for 6 weeks. And then you could also do that over a shorter period of time that's accelerated, or you could do partial breast radiation therapy, which you're just limiting it to just a region of the breast where the cancer was removed from. So more common if it's just a lumpectomy, for example. So just a brief overview of treatments. And then in closing, I just want to remind us about how important it is to be present, especially us as midwives, and especially if we were the first ones to feel an abnormal lump, or to be the ones that referred her to her mammogram in the first place, that we're listening to her story and that we're supporting her in her journey, and we were with her from the beginning. That's what primary care is about, being that continuity of care for her. And continuing to provide primary care for her. So the oncologists aren't wanting to treat her sinus infection, and oftentimes same goes for depression or anxiety or whatever else she's going through. And just a special shout out here for paying special attention to psychosocial and spiritual health for these gals. And I put our 3 things we're particularly assessing for and wanting to address for spiritual health. So love and relatedness, who is around her, who's supporting her, where is she finding connection, and then meaning and purpose, assessing for what kind of hope she has for her life right now, and helping to think about how we can be instilling hope, and then forgiveness. So the 3 pillars for spiritual health. All right, have a good week, everyone. And you would be amazed at all the beautiful tattoos I see with women who've had mastectomies, and it's up to them how much of reconstruction therapy they want to do, or reconstruction, is that what I'm trying to say? Surgery, reconstruction surgery they want to do. So anyway, lots of beautiful pictures out there. Okay, have a good week.